Good afternoon or morning, depending on where you are. On behalf of the American College of Apothecaries, it's my pleasure to welcome you to the important town hall discussion on PBMs. We don't really want to say that word out loud, but we have to these days. PBM reform, that's what we're going to talk about. We're grateful for each of you for being here today. This issue impacts all of us, our practices, our patients, the future of independent pharmacy, and getting quite a bit of press out there the last couple of days. Drug pricing anyway, and I think the PBMs have to be involved in that discussion. So I know that's part of what we're going to be talking about later on today. The American College of Apothecaries is proud to be facilitating this timely conversation, bringing together leaders with a range of expertise, experience, passion for meaningful change in our profession. I'm thrilled that we have a state senator here. I think that's awesome. And the PBM landscape continues to evolve, and it seems like every time we make progress, they move the cheese a little bit. It feels like that's what we're doing every day. Anyway, the challenges that we've had with transparency, fairness, access to care. Today, we're going to shed some light on that. Insights, discuss actionable paths forward. That's what I'm looking forward to, is give us some action by the end of this. All right, so our distinguished professionals, advocates have generously agreed to share their time and expertise. We've got some great folks here today. Tony Minitti is the owner of Camden Apothecary Dispensary and Bell Pharmacy in Camden, New Jersey. He's an ACA Fellow, currently serves as chairman of the board of the New Jersey Pharmacists Association, president of the Independent Pharmacy Alliance, a passionate advocate for the profession. Tony was recently named one of the top 50 most influential leaders in the pharmacy. We've got another one on this panel as well. Tony's leadership and commitment to serving underserved communities have made him respected in both state and national pharmacy circles. Dr. J. Phipps, the man who needs no introduction other than saying pharmacy gladiator. Everybody knows who you're talking about when you say the pharmacy gladiator. Jay's the president and CEO of Phipps Pharmacy, Phipps Care, Health Insurance Solutions. He's an ACA, ACVP fellow. He's in Tennessee. Jay leads multiple organizations that provide innovative pharmacy services, healthcare delivery, insurance solutions. Recently named, there are other top 50 most influential leaders in pharmacy on this panel. Unmatched energy, absolutely. Strategic vision to the field. On the board, currently serves on the board of the ACVP, and glad to see him here today. And this one's I'm excited about. Senator Evan Vickers, longtime champion for pharmacy and small business in Utah legislature and ACA Fellow. In addition to serving as the president of Bullock's Drug Store, Senator Vickers has held public office for nearly 4 decades. Recently served as Senate Majority Leader. Senator Vickers serves on the Utah Pharmacists Association Board of Directors, as well as the Board of Directors for United Drug and American Associated Pharmacies. His legislative accomplishments have strengthened Utah's economy, supported rural health care, and advanced the profession of pharmacy in meaningful ways. Thank you, Senator. We absolutely appreciate your time, taken away from all the things you've got going on. And then finally, the moderator today is Mark I. He's the Senior Vice President, Chief Operating Officer of NCPA, National Community Pharmacists Association. Mark brings more than 39 years of experience in pharmacy practice and leadership, including 3 decades in multi-site and specialty operations. His dedication to pharmacy education and policy make him an ideal guide for today's discussion. So you'll be glad you don't have to listen to me for the rest of this. Mark's going to take over this thing. Join me in thanking these panelists for their service to the profession and their willingness to engage in meaningful, critical dialogue. So, Mark, it's all yours.
So that was a shock to me. I didn't know it was a moderator, but I can certainly jump in here.
Sorry, I just want to throw that on there at the end.
No, that's perfectly fine. I can talk all day long, unfortunately. So, what I'd like to maybe start out is just have each person reflect a little bit on where we are, where we've been, and maybe what they've done as part of their journey. And we can kind of go in the same order that we were introduced. And Tony, if you want to jump in and just give a brief synopsis of what you've seen and where you think we're going.
Yeah, and I will try to be brief. That's not easy for me. As a recovering elected official, nobody loves to hear the sound of their own voice more than us. I'm sure Senator Vickers can attest to that. But I operate Camden. I operate Bell Pharmacy in Camden, New Jersey. For those that don't know much about Camden, it's a city not unlike a smaller version of what Detroit would be out in the Midwest. And it's a typically underserved urban environment, and skipping past a lot of the history and to why I chose pharmacy in Camden, setting aside the fact that it was a family business. One of the things that I noticed that made pharmacy in Camden, being in the pharmacy business in Camden, so attractive was in the 80s and 90s, in the beginning when I started, there were no PBMs. At the time, all there was a state-administered Medicaid plan and a program called PAAD, which served senior citizens, and it was an independent insurance fund that was created with casino money back when Atlantic City was first developing. So when all my colleague pharmacists were carrying on about their woes with PBMs and their cushy suburban practice settings, I had no idea what a prior authorization was. There was no such thing as AWP minus. If we had issues with how the plans were being administered by the state, we had a rather easy remedy. We would speak to our elected officials, and our state associations worked closely with them. And pharmacy really thrived in the urban and the rural communities that were mostly served by Medicaid, because that was where you could actually have a good practice and make a fair living at doing so. And at the time in the 80s and 90s, there was probably over 25 pharmacies serving a city of about 85,000. Now, we flash forward to today, after the PBMs were sort of let into the cupboard and the state got out of the business of administering pharmacy benefits and gave it off to the PBMs. 20 years later, 30 years later here, we are down to less than 10 pharmacies serving those same 90,000 residents. And the challenges of the urban and rural communities has not gotten any easier. So when people ask what's happened, much of it's come down to economics. A lot of it has come down to PBM tactics that have resulted from the catastrophic decision to allow the Merck-Medco merger. And then what really, I think, tipped things over was the CVS Caremark Aetna purchase. And what we've got now is just an acceleration of community pharmacy die-off that I think that nobody would have ever expected. There were no chains in Camden at one point. They eventually figured out what most of us independents did, and they started to locate here, most substantially Rite Aid, CVS, and Walgreens. Well, Rite Aid helped force a lot of the independents out of business. They're now gone, and there's nobody replacing them. Walgreens has abandoned Camden. CVS has long abandoned Camden. So we see how important it is to do all we can to foster the success of independent community pharmacy in our underserved communities. Because what many don't understand that are not from this environment is we're often the first contact that patients have with the healthcare system. They can't make appointments very easily. A lot of them lack access to transportation. And they come in, as they did when my grandfather in the 30s was running the pharmacy. They have a problem, they go to see the pharmacist. And the pharmacist either helps them address it with what we have in store, and if they need a greater level of care, we help guide them in that direction. So we're saving the system costs with no expense, by the way, because we don't get paid for that. We save the system billions of dollars in emergency room visits that are unnecessary or emergency room visits that are too late. So I've tried to kind of focus why that's an important necessity in all communities, but even more so what we have here in our urban and rural environments. And of course, as I always like to remind everyone, when we had everybody talks about our first responders and such during COVID, and somehow pharmacists are never really mentioned with doctors and nurses and first responders. Somehow we always, as we always do, we never get included in that conversation. And I work very hard to remind everybody how our vaccination effort, regardless of what you feel about the vaccination now, had failed in this country until independent retail pharmacy was allowed to come off the bench and perform. And we made that effort a success because in an extraordinarily diverse nation that we have, the only truly specialized care that's not one size fits all is provided by neighborhood community pharmacists. And that's got to be preserved, or that response and that ability, we won't be there to come off the bench when the next COVID inevitably happens. So that's where we are today. I will leave it at that. And Jay, go ahead.
I would just real quick, Jay, I would just like
Yeah.
to comment that, just to remind everybody, most people know these statistics, 3 pharmacies close every day in this country. And now we're, in the face of Rite Aid closing another 600 stores. There are pharmacy deserts popping up everywhere, including urban areas. And we can, the problem is CMS defines access a little probably incorrectly in my mind, especially in an urban area. Someone who doesn't have a vehicle and is, a mile away from a pharmacy is virtually can't get there. And so, one of the things that Tony mentioned that I think is really important for everyone to be cognizant of when you're talking to legislators, talk about patient access, talk about how impact on patients. I hate to say they don't care about you, but at the end of the day, they care about their constituents and what it is, how they're impacted, not how we are impacted. And I'll let Jay jump in.
Yeah, thank you very much. So I'm in rural middle and West Tennessee. I have four pharmacy locations, and just did the calculation. I'm 23 days from being in my 25th year as an independent pharmacist. I'm a first generation college grad, first generation pharmacy owner, business owner, and opened June 5th of 2000. So almost 25 years of doing this. And I'll be very candid. I came in and I went to work and I busted my tail to take care of patients day in and day out for probably the first 15 to 17 years, and wasn't as evolved as I should have been. What I saw really was that myself, along with much of the profession, missed opportunities to advocate for the profession because we were so worried about taking care of, Mr. Jones or Miss Smith that we didn't think about taking care of ourselves. And so one of my core values is really to act boldly. And that really changed about 10 years ago. And it's about making bold action. And so that's really where the Pharmacy Gladiator platform came from. It's talking about how we're fighting for our profession, fighting for our patients, and trying to conquer the Coliseum in our community, and really because we go to battle for our patients and our profession every day. And that transition of acting boldly led me to be involved in the Tennessee Pharmacists Association, which I was a president of, being able to be part of Tennessee Chapter 1070, which is our PBM reform, which got us where you can't get paid below cost, got a dispensing fee for many of the independent pharmacies of 1316, so NADAC plus 1316, and in pharmacies that fill less than 65,000 a year, can't get, as I mentioned, can't get paid below cost. It also funded what I kindly call a PBM czar, which is really not his job title. It's PBM compliance, and they've got 2 pharmacists in there. They're making PBMs be accountable for the actions that they have in the state of Tennessee if they're licensed. The other things that we've done that I've been part of, we've expanded our scope of practice where we're prescribers for vaccines, COVID, flu testing, TB skin tests, Narcan, EpiPen. We're expanded our scope of practice there. And then we went back after, I guess, our 3rd year of PBM laws and increased the penalty, so it's unlimited now. What we found out was we weren't proactive enough to think that, hey, $10,000 fine's not going to do anything to PBM. They just threw it away. And so it's just cost of doing business for them. So we just redid that. So now it's unlimited. And I don't know if y'all have seen, but in Tennessee. We just audited Express Scripts, the Tennessee Department of Insurance and Commerce. And I know it's hard to believe, but they're paying their pharmacies up to 3,000% more than what they're paying independent pharmacies. 3,000, up to 3,000% more than for their affiliate pharmacies than ours. We know that now. We've always thought that, but now we know it because the state is auditing and releasing reports. So I'll be very candid. I've never been more excited about the profession of pharmacy. I know we're on a tipping point. But after 25 years, I have never been more excited to practice pharmacy because I think we are really on the precipice of moving forward and doing great things.
Thank you. Senator Vickers?
Yeah, thanks. I've been involved with pharmacy for a long, long time. I started out in a very small town. I grew up in a small town of 2,000 people in southern Utah. Went to school at the University of Utah. When I went back to my hometown for a few years, and then moved to Cedar City, which was the big metropolis in southern Utah, 35,000, and been here since. Our family and I own 2 pharmacies in Cedar City, and then we also own one in another location 2 hours away in central Utah of about 10,000 people. And been involved with the, mentioned in the bio, United Drug and AAP for a long time. So I've been advocating on a federal level, trying to negotiate and work with legislators. And then I've been in this is my 17th year in the legislature. I served 4 years in the House and the rest of it in the Senate. The past 6 years, leading up to this year, I was the Senate Majority Leader. And so I've been involved in those types of things. And I'm the only pharmacist in the legislature in Utah, and actually only the second one that's ever served. And I can just tell you from experience that every state needs to have 1 or 2 legislators that are pharmacists, and trying to, that goes a long way, because the biggest challenge you have when you're dealing with legislation, dealing with PBMs, is trying to explain to a layperson, especially, or whether it be a legislator or a staff person or someone else, how complicated this is, because it's a complicated process, and to try to explain that it's not traditional business language. There's just too many acronyms, and there's too many challenges in the relationship that the PBMs have developed with, the payers, and how the even to the point that our own state employee insurance program, who deals with Express Scripts, I've tried for years and years to try to work with them to try to help them understand how they're losing money by the contract that they have, and they have pharmacists on staff too. I don't get it, but it's very complicated. It's a complicated process. We've done a lot of things in Utah. We've done, when we did our audit legislation, when we did MAC pricing legislation, when we did DIR transparency, all those things were cutting edge. They were leading out. The challenge you've got, and when you start thinking about it on a state level, and I know that each state will vary, but for the most part, the only thing you can affect is the commercial market. All federal programs are exempt, so Medicare, Medicaid, VA. For the most part, ERISA is. I know that there's still some pending stuff in the courts, and there's a little bit of an open door there, but it's still, for the most part, you can't govern ERISA plans. So in the state of Utah, for example, when I first came in the legislature, the commercial market was about 60% of the market. Now it's 22%. So when we do legislation, no matter how good it is, it only affects a small portion of our business. And so that's why this action and kind of the energy that's going on right now on a federal level is exciting, because that's where it really, long-term success, that's where it's going to have to happen. We have examples in the state of Utah, really good examples in the state of Utah of how PBMs can be effective and be fair. Select Health, it's part of the Intermountain Health Program, which in the state of Utah, that's the big gorilla as far as healthcare in Utah. And Select Health has their own PBM. They're very fair. They don't use DIR fees. They're very fair in the reimbursement. They're run by pharmacists. And Medicaid program. We don't, I know a lot of Medicaid, state Medicaid programs are farmed out to PBMs. Ours doesn't. We have 50% of it is their own PBM, and 50% is through ACO, which does have PBMs. We've just been successful this past year of increasing the dispensing fee on both of those up to a level that's reasonable and fair. And now I finally this past weekend been successful in getting the director of Medicaid and the director of PEHP together and talking about using their own PBM to manage the whole thing. So there's possibly, there's good examples there, but the big challenge you've got is, number one, trying to talk to other legislators and help them understand the challenges. Number two is there's huge dollars that come in. PBMs and pharma have the largest number of lobbyists anywhere. I don't care if it's on your state capital or in DC, and they're singing their song, and they have a very good strategy, and they work they're very close. They line up with leadership. They try to get people in leadership behind them and understand, so that they're beholden to them. And those are challenges. And one of you mentioned, Tony, it might have been you, that when you're talking about PBMs, talk about individuals and talk about access and care, talk about families, how it affects families in your state. Just went through a massive effort on 340B legislation this past year. And I got to tell you, the selling point that finally won over was how it affects families in the state of Utah. And believe me, it was a all-out battle, and we came out on top. But it's being challenged in the courts, and so just like all those pieces of legislation are. But anyway, it's been very enjoyable to be part of it, and I look forward to a few more years.
Yeah, I would reiterate that, being active on a state and a federal level is important. At NCPA, we think that the states are actually beginning, as I say, the domino effect is forcing federal legislators to look at, if all these states are passing things, why haven't we done anything? An update for those of you who may not have seen it, last night, the House Energy Commerce Committee did incorporate elimination of spread pricing and reasonable dispensing fee in Medicaid managed care into the budget reconciliation program. And there seems to be some real good vibes, for lack of a better word, that it'll actually go through. So we're making some progress on a federal level, and we got to continue to keep pressing. Many of you may have seen NCPA's Finish the Fight campaign over this last year. We had over 85,000 patients contact their legislators in DC, but we can't stop now. It'd be the equivalent of being a lap ahead in a race and letting off the gas and letting everyone go by us. We can't do that. So I'd like to address some of the questions in the chat and some that we pre-received. Mostly, some of this is more federal, but it can affect states. Someone asked if reform were able to get NADAC pricing, is that actually going to help pharmacies' overall profits, or is that just a shift in creating a new average? And is this really the best option moving forward? I have some thoughts on that, but does anybody else on the panel have thoughts about NADAC and whether NADAC is the right option for us at this time?
I could start off with that, Mark. I think that's not going to be all that tremendously helpful over the years, and I predate you, Jay, by a few, so I don't feel so bad about not having that level of energy that you have. I can tell you that whether it's AWP, AWP minus, WAC, NAC, we always come up with these reimbursement schemes that make it product-based. We have to get away from the product-based reimbursement model first and foremost. They're always going to find a way to confuse that, whether it's renaming something a generic effective rate versus a MAC. What we have to focus on are a few simple things that affect the system structurally, top to bottom, at a federal level and a state level. First and foremost, the idea of rebates. Rebates are the driver of high drug costs. And Mr. Senator, I could tell you that I always try to, as somebody who had to deal with hearing ideas from advocacy groups, I understand you have about 5 to 7 minutes of an elected official's attention to make your point, or to get them at least thinking about it. So I try to make it, very simple bullet points. When it comes to this pricing model, we've got to get away from the idea of rebates, because rather than the GLPs, take that for example, rather than them all competing for primary positioning on a formulary based on who has the lowest price. And ironically, you're seeing that now is Novartis went to the $400 plan that was driven by the compounding. And then Lilly went, and now they've got their program for $400. Rebates incentivize the exact opposite, because they have to raise their prices higher and higher and higher to afford to pay the most to get their rebate to be the one that puts them as the top tier person. So instead of competing for the best price, they have to raise prices so they can give the best rebate. And the only people that really profit from the rebate, of course, are the PBMs. You have to get rid of spread pricing. The idea that we get paid $1, the insurance plan gets charged 10, and the PBM keeps 9. That can't be permitted to happen. Something that for those who didn't watch today's Senate hearing, I would recommend going on senate.gov and watching it. It was exhilarating and exciting, and I hope it's more than just talk, and I hope they go forward with it. Mark, I don't know if you saw it before we got on, but it was some fantastic stuff. Very rarely do we see Republicans and Democrats all together bludgeoning the PCMA rep, but that's what they were doing. You have to break up this vertical integration where PBMs are permitted to have their own pharmacies. It's got to go. That's the first and biggest step, because everything that's done by the PBM is meant to enrich their pharmacies, their subsidiaries, their profit centers as their pharmacies. It's not, yeah, sure, they're making money off the rebates. They're making money here and there. They're making their money in the pharmacy. All that money is being siphoned off. And you're going to love this, Jay, because J.C. Scott from the PCMA testified under oath that there is no difference in the reimbursement rates and what is paid to any of the affiliate pharmacies. That's not true. They told the Mr. Sood, or whatever the professor was that was presenting his results from a study, he said that's incorrect. Their members don't pay their affiliated pharmacies any more than every other pharmacy. This is what he said under oath.
Well, it's unfortunate. It's not the first time we've seen
we know
not the first time we've seen a PBM person lie to Congress.
Yeah. So what I will say is so encouraging about where we are today versus where we were when I graduated in 1993, and then in 2000 when Jay joined the fight with us and everybody else is. You're right. People don't understand what a PBM is, but today they understand PBM equals bad. And that is a huge step forward, because when you're going into it with a different idea, nobody knew what they were. Now people don't know what they are, but they know it's not good. So that's a good place to start, especially when you're talking to your elected officials. And, I framed the presentation as I would frame it to me, as I said earlier. I said, if somebody came to me as an elected official at the state or federal level and said, if you enacted 5 reforms or 4 reforms, you could solve the problem of pharmacy deserts, which is something everybody universally recognizes. You could ensure that care is provided at the highest level to underserved urban and rural communities, something that everybody understands. You could create jobs in those urban and rural communities. And you could do all of this while increasing the quality of care and decreasing the cost of care to your taxpayers and to your constituents. Would you do that? And universally, every elected official is going to say, of course, tell me more. How do you do that? What are these 4 steps? And I always like to just get into those simple 4 bullet points. Elimination of rebates, or rebate transparency if you can't get rid of a rebate. You know, PBMs being prohibited by federal law the same way we broke up Standard Oil and Ma Bell is the same way these PBMs need to be broken up. I said in my written testimony that the Rockefellers and whoever was in charge of the phone monopoly back in the day would blush at the monopoly that the big three PBMs exert on our entire healthcare system. So you've got to get them out of the business of pharmacy altogether. You take these simple actions, and you're going to see what a difference it makes. Have transparency in price competition. I'm going to address one thing more because I know that it was it was addressed today in the hearing, and I noticed it was one of the topics that was outlined as part of this chat, and it talked about it talked about the idea of, see there, I just lost my thought in my own head. Let's see. Well, it's going to come back to me.
Well, Jay, you want to comment while he's?
I got so ahead of myself.
Okay,
I forgot I forgot the point that was the one I wanted to make the most. But go ahead, Jay. Jump in. You'll probably cover it for me.
Any comments on NADAC rebates, transparency, spread pricing?
So if I talked about a little bit NADAC, I really think we need to start looking at a cost plus model. I really think that's where we're going. We can get in the weeds with how you come up with that. But it really needs to be, if we're going to do a product model, it needs to be cost of the drug plus a percentage plus your dispensing fee or whatever your margin is on top. I think that's it. Now, I'm a firm believer that we need to be patient care providers. The advantage I think that pharmacists have versus other healthcare providers is because they are already tied to us. We have a book of business. We have patient coming to see us for the product. And I know that's how we've paid the bills for years and years. I think we use that as the don't like the word bait, but bait, that's the attractant to get people to come see us. And then we work on how do we take care of patient at a high level and then not do things for free like we have in the past. The one thing I'm going to add real quick is we talk about the complexity. I've heard more than one person talk about the complexity of PBMs. I think of it like you got a young mama coming to see you. She comes in with an antibiotic. You don't talk about the mechanism of action. If you're using Cipro, you're not talking about DNA gyrase, right? You're talking about what you're going to do is you're say, hey, here's a medicine you're going to give your family member. Here's how you dose it. Here's what's going to happen. Here's what you should expect. And come back with me if you've got questions. That kind of thing. When we talk about PBMs or access to care or the barriers that PBMs put between us and patient care, we need to do the same way. We need to tell a story. We don't need to do all these facts and, you need to be supported by fact, but it need to be very clear, just like you're speaking to a family member, as a patient and how they care for themselves. And think about, we're storytellers, we're educators, and we're motivators. And so when talking to me, if I'm speaking to Senator Vickers or a new patient that comes into pharmacy here in a few minutes, I'm going to use the same thing. I'm going to talk where I think that they can understand it, make sure it's clear, and you really shape the narrative based on your audience. I think that is a gap that pharmacists have. We want to go in there and we want to word vomit everything that goes on in our practice, and really what they want to hear is they want to know how it affects patients. Depending on the party, they could want to know how it affects jobs and employers. It just depends on the legislator.
Absolutely. Senator Vickers?
Yeah, thanks, Mark. Just to follow up on a couple of things. Rebates, yeah. Well, back to your original question about, pricing. It's kind of in my experience over the years, PBMs have been able to take pretty much anything we do or we want to do and twist it in their favor. it's a lot like playing whack-a-mole. You know, you close off one problem and another one pops up, and it may be just a variation of the previous. So I'm not sure that you know, going to one of those models works. You know, Jay's idea is probably the best, you know, to try to get to something along those lines. Rebates definitely are an issue, as you know, I think you've explained pretty well, but if you look at it, the rebate model is getting you know, it creates it does in pharma. And when I've had conversations with pharma, they admit that rebate, you know, the way it works, it does drive costs up. We have an organization here in Utah, it's called Civica RX. It's a break off of Intermountain Health, that they started their own company to start manufacturing drugs, primarily to help with their hospital system shortages and other things, but now they've branched out. But they went into the insulin market and a number of others. And the director of that is a good friend of mine. I was talking to him as he was having conversation with a PBM about, you know, putting their drug in. The exact same conversation that one of you mentioned, Mark, it might have been you, where they said, you know, you've got to raise the cost of your drug so that we can use a rebate. And he says, I don't want to use a rebate. I just want to, I know what it costs me. I know what profit I need, and that's what I want you to charge. And they literally wouldn't even sign a contract with him. So that, you know, I think we're on to something there. And, you know, and I don't know if this, you know, the new executive order that Trump's talking about with favored nation, if that moves the rebate program out of the market, maybe that's a good thing. If it if it goes farther and disrupts the 340B program, probably not a good thing. So we'll have to see how that kind of all plays out. Spread pricing, it's interesting as you talk to payers, and I've talked to many payers over the years as I've tried to do transparency type legislation. I asked them, do you know what the pharmacies are being paid for that prescription you're getting? You're paying that $10. Tony, you mentioned $1 and $10, you know, and they don't. And I said, well, why don't you audit your PBM? And well, it's written in our contract that we can't. I says, well, change the contract. And so then they changed the contract, and they're still afraid to audit them because they're afraid of retaliation from the PBM. So it's still out there, but most payers don't even recognize the fact that there's a problem.
And,
Yeah, and
and unfortunately, most payers are also what I call drunk on rebates.
Yeah.
They like the rebate program because what happens in a lot of health systems and large companies, those dollars come back in offline, and they're able to sort of reroute them into their business model almost as free money, even though they're overpaying to get to those rebates. And you know, some of the things you may need to do in your communities is not just talk to legislators, but educate your large employer groups. And one part of the puzzle that many people don't talk about are the TPA brokers that sit between the employers and the PBMs, and they can make they sign contracts for the PBM, and many contracts they sign, they get paid $1 to $3 a script filled during the term of that contract. Think about the volume of money that these middlemen brokers are pulling out of this system. It is, you know, we sort of have to look when I look at PBM reform, we can't touch one person in the system. We have to educate each person along the path so that they understand exactly what's going on. So Senator Vickers brought up the executive order. We spent 2 hours this morning here talking about it, what we think is going to happen, what we hope will happen, because it was very vague. Any thoughts on that? I'm going to skip Tony this time because he go right to Jay.
Well, you know, I just started looking at it the last couple of days, and I've got a friend of mine that's he and I have been talking about you know, some of the potential executive orders and where they're going to come out. I don't know. You know, my wife even asked me this morning. She said, you know, she heard it on a talk show, and she said, "Is that going to be a good thing?" And I says, "I don't know. You know, it could be if it does break down this rebate structure, where." And you know, and it's interesting because PBMs will tell you that 100% of the rebate is going back to the payer. Well, they forget to tell you that they've taken out their management fee, which can be significant. And but so if it breaks down that structure and gets pharma back, and we're typically talking about, primarily we're talking about brand name drugs. If we can get a brand name drug back to the actual landed cost of what that drug is, and just sit it there, like any other retail product, then that's a good thing. But but I don't know. I really am still unclear. I don't know. Mark, I don't know if you
I
asked.
met in my former life, I met with about 300 manufacturers a year in procurement, and almost all of them said they would gladly give up the rebate programs because some of them pay as much as 65% of the cost of the drug in rebates and fees. And so, I mean, if you just do the simple math, they can give up 3/4 of that and bake in a little bit more profit. We all benefit if we can get rid of that rebate. And we read it the same way. We're hoping that's what they mean. They talk about direct to consumer. I don't think it means direct to consumer as we think about it. I think it means more either rebate at point of sale and or lower costs to the consumer using pharmacies. And that's what we'll be advocating for, to make sure that you've got an infrastructure of 50,000 pharmacies in this country that can deliver this, this tomorrow, if you're given the right tools to do so. Jay, your thoughts?
I'm very much like Senator Vickers. It's an unknown, and I really I don't mind uncertainty, but there's a lot of uncertainty at this point. I think what this could do if we could get rid of the rebate structure. I agree with Senator Vickers 100%. I mean that'll immediately drop drug pricing. The one thing I think that could impact us immediately is if this could put a pause on the IRA price negotiation drugs. If we could pause that, that's going to be a negative impact to all of us and our cash flow. So if that could pause that, because we should be able to get prices lower than what they've already negotiated. And I think President Trump commented about President Biden's negotiated prices. So I think that'll be interesting to see. I think there's just a lot up in the air. Now, I did see where Kennedy said yesterday that he specifically said to get rid of the middlemen, which I'll be honest, I spent a lot of time reading that direct-to-consumer quote. I read it. I watched it about 12 times to see if I misheard that. And then I went to explore and do some other things and found, so hopefully that we were talking about using the distribution network of pharmacies, community-based pharmacies to do that. And from what Kennedy said, it sounds like that would be the case. It'd be interesting to find clarity as time goes by.
Yeah, I don't know if you saw the Kennedy clip. He was on a news channel and he actually called the middlemen PBMs. So he did do that. One of the things we've seen, unfortunately, is pharmacies are lumped in as middlemen. And, they got manufacturers, they've got consumers, we're considered middlemen. We need to change that narrative for sure. Tony?
I'm going to throw something a little out there that may seem crazy, but if you watch the way President Trump has operated, there may be some logic to it. I don't think that he necessarily wants. His goal, I don't believe, is getting all the drug companies to offer their drugs at prices lower than what they have on the market. It's unattainable. It would be tied up in court for years. It's politically dicey at best. I think it's a maneuver to somehow separate the PBM and the manufacturers from one another and have the manufacturers say, well, look, we would love to compete on price. We would love to be able to offer our drug and say, you know what, ours is the best and we can get it at the best price. We're willing, but we can't. We have to pay these rebates. And now you're starting to see the curtain pulled back on the PBMs. Now the PBMs are a little bit out on an island, because how are they going to defend what's a mathematical fact? And that's that these rebates are what drives the prices up and inverts all the incentives. And I did, by the way, remember what it was I wanted to address that was in our little agenda. And it had to do with how we're dispensing drugs at a loss all of a sudden, and how that wasn't happening. And that was the subject of today's hearing. And, I don't think that they addressed it sufficiently enough in the scope of why it means PBMs should not have their own pharmacies. Everything is below cost these days because it's a calculated effort to force pharmacies to transfer non-profitable prescriptions out to the PBM pharmacy. That's what it's all about. And we had this happen to us on several lines of business where right now your contract year is a year. Okay. Prices really shouldn't be changing over the course of a year when the price of the drug isn't changing. But what we noticed is Optum would continually just keep lowering our reimbursements, somehow we would be able to continue to get the product, whether we procured it on the secondary markets or different sites, and they would keep lowering it, and they keep lowering it till they know you can't afford to dispense it anymore. And that's generated specifically for especially the higher cost drugs, anything over about $500, to force you to transfer it to their PBM. So that's why I say the pricing game is one that we kind of have to, maybe avoid. Stick with the model of a cost of product is covered, and we don't exist anymore on the markups like we used to. It's more based on a fair dispensing fee or payment for extra professional services that we never get paid for. That's where that model is better. But this it was something that was in the 3 bullet points that we wanted to cover, and it's something that I've witnessed happened in real time because I watched it happen to us. When you are filling too many what they deem to be specialty drugs, and that's anything that's profitable these days, they will just keep lowering that reimbursement until you can't, there's no way you could buy it at that price. And then it transfers to them. And Senator Vickers, in my township, my first real exposure to spread pricing was a product called Pensed. A lot of our police officers were on it for, orthopedic injuries. Now, I know that when I buy that drug for $23.85, PBM typically pays us, if we're lucky, $2,400. So we're making, $15 on a $2,000 something prescription. They were charging our health plan $5,000. We were making 15. They were doubling the price, and they were keeping the difference. That right there is the example of everything that's wrong. And that's one product. And when you apply that across the universe of products, especially when everything is so expensive these days, that's why you see what you see. They get, and we mentioned they'll get around laws. Any willing provider law, take it or leave it contracts. Well, you take it because you have to. You don't have a choice. Something that was also brought up in today's hearing, which is good to see. But what they do is, fine, take the contract. We'll just keep changing your reimbursement until you don't want it anymore and you can't participate anymore, and we take it. If they didn't have their own pharmacies, that now they're getting, think about this, now they're getting the plan premium, they get the rebate, they get the processing fee. Once they now get to pay themselves for the product and keep the spread, they now own every piece of every link in the chain, every point in the process. They're being paid again and again and again and again. And that's one of the, I don't know how we illustrate that on a simple basis, but that's why. And if you remove them out of the pharmacy business, that motivation to direct prescriptions now and steer patients is gone. I think back to the old days when insulin and, diabetic supplies, our bread and butter patients were those that got insulin and syringes every month. The minute it went to the PBMs, within 3 months, we lost 1,000 patients. No bad interactions, nothing happened. They sent a letter to a doctor that makes them think you have to get it at their mail order pharmacy, and the patient's gone. And this has happened all across all of the sorts of therapies that we could count on as solid, monetizable, if you will, business. So you've got to get them out. You've got to get them out of the pharmacy business. They never should have been there. No other sector of insurance do we allow insurance companies to pay themselves, except for in pharmacy, and that's got to change.
Yeah, I can comment that, one of the good pieces of news we've received in the last couple of weeks is that the FTC is going to pursue these vertical integrations. Sher Khan, who is the former FTC chair, started that process, and the new chair, Ferguson, is picking up where Chair Khan left off. And it looks like they're going to be going after these verticals. And you're absolutely right. When you own the entire segment of the business, I always talk with friends and I say, they got in an uproar about, multiple cable companies combining, and somehow people's health care doesn't seem to be as critical when we look at those kind of things. One of the questions was pharmaceutical wholesalers complicit as the PBMs. I don't want to get into that whole discussion, because I can't see who's on here, but they, to a certain extent, they're victims of the process. The pharmaceutical manufacturers are forced to charge, their cost plus rebate fees, which again doubles the price. And it goes back to what Tony said. At the end of the day, the wholesalers could lower the price tomorrow. And every time we've seen a price decrease, a WAC decrease, the PBMs step in and absorb all the differences that are made up. Nobody wins except them. The patients don't win. We don't win. So I don't want to give the wholesalers a pass, but I think that they're somewhat of a victim as much as we are. And I can tell you, the pharmaceutical manufacturers are in a world of hurt. And one of the concerns I have about a lot of the things coming down is innovation in the future. We may not see as much. When you take the top 10 drugs and you reduce their WAC significantly, is there a reason to bring a generic out? Generics come in at 85% WAC traditionally. Why would anybody want to make a product that's not making any money? One of the consultants I talked to a couple of weeks ago said that there's not been a successful pharma launch in 4 years. Not a single product that's hit the market in 4 years has made any money because of the rebating and the spread and everything else that the PBMs are doing. So I know we have probably about 5 minutes left, and I just want to get final thoughts. If we can start with Jay this time.
I think at this point, what I would encourage people to do is to remain relentless. We have to keep the grassroots effort going. We have to, to make the connections with your legislators. You need to have pharmacy visits, tell the story. Just need to continue to tell the story, build those relationships with your legislators and tell the stories, and then get your patients to tell the stories. Everybody's got, even if you don't have hundreds of people, you may have that 3 or 4 or 5 or 10 that are passionate about your pharmacy or about the care that you give, or their fear of losing that with the current situation with PBM. So I think we continue to hit that, and we do it not just from a profitability of the pharmacy perspective. I think that is a secondary model. We have to continue to talk about patient access, quality of care, and how we do a great job of taking care of people, and how their constituents, our patients, will suffer if we don't take care of them.
Tony?
We're at a historic moment right now in this profession. I got to be honest, Mark, one that I never believed actually would happen. I mean, to see what's accelerated against the PBMs and kudos to the work that NCPA and all the partners have done in that effort of raising the profile of this problem. We are at a historic moment for this profession. And if those of us who are probably towards the later years of our profession, like myself, want to see the next generation come in, we can't let up. And those that are just getting into the profession now, they've got to get active like they would in any other of their social causes. And these kids are so great with that today. The public wants community pharmacies. The public likes access to their community pharmacies. We're seeing that in the end, you can't depend on the big companies like Rite Aid, like Walgreens. I worked for Thrift Drug, which became Eckerd, which became something else, which became, then they're all disappearing. Now the big chains are all disappearing. Who's left? It's us that have been able to eke this out. We're what the public wants. Everybody loves their community pharmacist. And we've built that goodwill over generations. And right now is when we need to take that capital and unite our patients behind us and have them standing up and saying, this is who takes care of us. Elected officials, you need to ensure that they're here tomorrow when I need to go see them. This is our moment. And that's why this is so important. Jay, you're exactly right. This is not the time to even let up a little bit. There is no celebration. There is no victory lap yet. We got a long way to go. And we've come a long way, but we've got a long way to go, and we can get there. I've never been more optimistic or confident about this fight than I am right now.
I would agree. Senator Vickers?
Yeah, as far as the profession goes, keep doing what we do best, taking care of patients, providing good, high quality care, be good business people, run your businesses well so that you're profitable. And then we're going to be involved. We're going to be tied to legislative issues for many, many years. And it's just the way of the profession. So, Jay mentioned relationships. I will tell you this, that is key. A good friend of mine used to tell me that he and I were on the board of AAP together, and he said, you got to have a relationship of 5. You know, your state senator, your state representative, your U.S. congressman, and your 2 U.S. senators. Now, what does that mean? Well, you're going to have to spend some time developing those relationships with their staff and others, but invite them to your practice settings. They'll come. Some of them, you know, on a state level, they may be your neighbors. You know, they may live in your town. You know, it may be easy, and I can tell you this from experience that your U.S. people, the Congress people, they'll show up once in a while. So yeah, just keep doing that. And then, as has been mentioned by both Jay and Tony, you know, tell your story, talk about the challenges, be simple and straightforward. And by the way, never, ever, ever, ever use a cut and paste email. So they get read once, and the other 999 go in the trash. So.
Yeah, I can tell you that we've been told that, you know, from our perspective, that they have, for lack of a better word, artificial intelligence that go through those and can identify those in today's world. And I would reiterate what everybody has said, is that number one, we've got to keep up the pressure. Even if we get, I hate to say everything we're asking for today, tomorrow, we need to be preemptive against what the PBMs will do, because they've got thousands of people sitting in a building somewhere plotting against us. And as one of the consultants said at one of our meetings in recent past, they already know what they're going to do in response to these bills if they pass, because they've been plotting against us, you know, for some time. To quote what I've heard many times, and I can't tell you who said it because it's probably been said long before I was born: if you're not in politics, get out of pharmacy. You've got to make those connections and connect with the associations, your state, your national, your buying group organizations. Get behind them, support them. I know that, you know, I hate to talk about money, but sometimes these organizations need some money to continue to fight on your behalf. And that's your buying groups, that's your state associations, that's all associations. And then get in, for lack of a better word, the face of the people that represent you, both on a state and a federal level. If we win these fights, you know, then we can go after things like provider status. We can begin to look at practicing at the top of our ability, things in a lot of states we can't do today. So I'll just end with, if you're not overly involved, and you are to some extent by being here today, make it a personal commitment that this year you're going to get more involved, whatever your level of commitment is, and engage, and keep this, you know, keep it simple. Tell your patient stories. They love to hear patient stories. I hate to say they don't care about, you know, whack and whack minus and all those things. It's are you going to be there tomorrow to serve the people that they represent? And with that, unless someone from the head group here, I guess that'll conclude today. And I appreciate everybody joining us. I'm not sure if our contact information is out there, but for me, if you need anything from NCPA, my email address is on our NCPA website. It's very simple, mark.ey@ncpa.org. Feel free to reach out to me. I might not be the right person, but I'll connect you with somebody in our team, whether it's advocacy, state legislation, whatever we can do to support you. And I thank you for your participation today. Stay well, keep up the fight.
Thank you. Thank you, Mark. Thank you, Linda.